Hey everyone, welcome to the first ever episode of Titans of Healthcare. This is through the Slice of Healthcare podcast network. I'm your host, Jared Taylor. Today, for the first episode, we have quite the guest list. We have Mehra from HealthTap, Nick Desai from HeyRenee, Dr. John Shufeldt from MeMD, and Michael Gorton from Recuro Health. Gentlemen, it's great to have you all here today.
Excited to be here.
Great to be here.
Well, if we can quickly start out, we kind of talked through this a little bit before we started rolling, but we'll have a breakdown for everyone to go to your sites and learn more about your companies. But I figure we can kind of go one by one, maybe in that order, right? Sean, Nick, John, Michael. Just give us a little, give us the 30 seconds on your background and your company, and then we'll go into some of the cool topics that we have in store for today.
Sounds great. It's a pleasure to be here. My name is Mehra. I'm a founder and CEO of HealthTap, one of the original companies, along with my peers here, founded back when digital health was called Health 2.0 and eHealth and mHealth. So HealthTap is focused on putting a long-term primary care doctor at every American's fingertips, regardless of their insurance coverage or lack of coverage or high deductible plan. And we aim to do so affordably and conveniently through a direct-to-consumer subscription model that has been working out very well for us.
Thanks, Sean.
Cool. I'm Nick Desai. I'm have a channel here on Slice of Healthcare called Nick's Notes, so many of you know me. I'm the founder and former CEO of Heal, and now the founder and CEO of HeyRenee, which is a digital care coordination company.
Hey there, I'm John Shufeldt. I'm an emergency medicine physician, founded an urgent care company in '93, and then in 2010 founded MeMD, which we just sold, which was a kind of early digital healthcare company for both virtual care for virtual urgent care, and then it went to behavioral health and primary care. We sold it to Walmart in June of 2021. Pleasure to be here.
All right, and I'm Michael Gorton. I kind of did the rough math on this. The titans of healthcare on this phone call are north of 75 years of experience, which is not bad.
Wow.
So most people know I founded Teladoc, started building it in 2000, and then started Recuro about 2 years ago. And so Recuro is all about lowering costs, improving outcomes by being preemptive.
Oh, thank you, everyone. Yeah, it's going to be a tough episode to follow up. I mean, this is our first one for this show. It's going to be interesting to see who we can get to follow. But really appreciate having you on the podcast today. One of the first core topics that we kind of want to go into, and we can kind of go in this panel format if it makes sense, and probably the best way to do it, unless you have something that you kind of want to add on top of someone, is to maybe we continue with this order that we have here today. But really, we want to try to make this as collaborative as we can, because I know you all have some different opinions, but also some similar opinions that we can kind of piggyback on one another with. So since we have the OGs of the digital health space on here, one of the first things I want to kind of talk about is really the early challenges of virtual care, and just kind of showcase how far we've come, because we have come a long way here. Sean, first let's kind of hear your thoughts on. I'm sure you share a lot of the early challenges that everyone else here has had, and we can kind of, like I said, piggyback on top of each other, but curious to hear your thoughts, and then we'll kind of go down the list of early challenges and kind of showcasing how far we've come as a industry.
I think it's nice to start with some retrospection to just appreciate how far the industry's come in 12 years. I mean, when Michael, John, Nick, we're all getting started, I mean, there are things we take for granted today that you can't take for granted. Telehealth, not much more than 10 years ago, amounted to pretty much a nurse hotline by telephone. And today, you take for granted that we all have bandwidth on our mobile devices with, high definition cameras. You take for granted today that doctors are not freaking out about getting sued for what they say to patients on the internet as much as they used to be. You have infrastructure and APIs for e-prescribing and for health data storage. And you have out of the box integrations for lab testing companies. There's just so many things that have become expected now if you were to launch a telehealth venture that many of us pioneered to get us to where we are today.
It,
Yeah, sorry, go ahead, Jared.
no, I was just gonna say, Nick. I was gonna tee it up to you. See
Okay.
what your thoughts on this.
I mean, I agree with everything Sean said. I would just add to that that one of the one of the most important things that's happened over the last half dozen years and then accelerated by the pandemic is this: everything should happen in my house for me, right? My food gets delivered by Instacart, my cooked meals get delivered by Grubhub, I get, my content comes via streaming, my dating, they're using Tinder profiles, and this isn't funny, it's sad, but Russian soldier Tinder profiles to find out where they are inside Ukraine right now, right? Everything is happening from my phone and my home, and I'm working from home, which the work from home movement, right? And so I think that it's a why not healthcare also happening at home, right? When we started Heal in 2014, I'm not as OG as some of you guys, but 2014, people were like, no one's ever going to let a doctor in their house. What the hell are you talking about, right? I distinctly remember a president from one of the four largest insurance companies saying, I look forward to going to a doctor. A doctor's office is one of my favorite places to go. That person doesn't work there, but that company has changed its position to be making huge bets on home centric primary care. So I think overall society has changed, that my home isn't the place I go to sleep, it's the place I do almost everything.
Yeah, I would agree with Nick and Sean. Micah was in this way early, and so even back in 2010, when I told people about MeMD, they go, "Wait, what?" And I'd always laugh and say, "You could save someone's life in the emergency department," and they'd be like, "Well, yeah, that's what you're paid for." But you treat a woman at 3 a.m. with a UTI, and you're like Moses. I mean, once they did it once, they were totally bought in. So it went from kind of this weird oddity for these very early adopters, and I mean, again, Michael was a true early pioneer in this. So I'm walking 10 years later, and it's still, you must have had 10 years of pulling your hair out. It was still pulling my hair out for about the first 5 years before people really started to beam up for the fact that, hey, this is kind of cool. And like Nick said, people are moving towards this home-based care, but man, it was a slow move pre-pandemic.
Yeah, and just to sort of put the icing on that cake, Jared knows what I'm going to say. They told me I was going to go to prison, so that's that's where we were. That's where we were back in the 2000, 2004 time frame. Was, the investors always say, "Well, what keeps you up at night?" Guys coming into my office with guns saying we're shutting you down and you're going to prison. That that was sort of the beginnings of how we plowed through this and got to where we are.
What's interesting too with what you did with Teladoc, right, is it can typically be a death sentence being too early in an industry, and you are still able to be very early and still be around, many years later, and not just around, continuing to flourish. I feel like that doesn't happen, especially in healthcare, right? Being too early is even probably being too, but I feel like in healthcare, you almost need to be early and then just kind of ride the ups and downs until you can get to that point, like where we're at today, where uh, you, I've been hearing it's not going to be healthcare. It's going to be virtual. Like everything's going to be virtual care or like a hybrid model. And if you're not, you're going to be left in the past. So really interesting, interesting thoughts from everyone. So thanks for sharing. Let's kind of tee that up and maybe we kind of, we kind of continue to we'll go in reverse on some of these questions so that everyone has the opportunity to kind of piggyback. So I'll tee it back to you, Michael. What do you think needs to happen for virtual care to continue to move forward? In a post-pandemic world.
Right. Well, a lot of the doors are open now, which is really nice. But I think that the innovators, the men on this phone call today, need to keep innovating because we're gonna continue to see resistance, and it's resistance because we've been doing things this way forever, because we're making money, because whatever the reasons are, and we just need to not let those people that aren't willing to accept the innovations and the things that are taking technology and bringing it to healthcare. We've just got to keep pushing it.
I would like to think that Nick's comment about the CEO from the health plan are days of old. You would hope now, kind of post pandemic, that people have seen that okay, healthcare is going to be a lot different. So we'll start doing, lab tests at home, imaging directly at your home, and all the virtual care models that you guys are all doing. You would hope that at this point, people be like, okay, I guess there's something to this. What else can we do? As opposed to the Nick story or all the BS you had to go through, Michael, to get where you went to.
Yeah, I think that I think there are three things that I always talk about. The first is the endemic force of resistance here at this point is I don't think the insurance company, the payer contingent, because they want to embrace lower costs and they want to embrace more primary care and preventive care so that the overall healthcare costs go down. And I don't think it is the government as a primary resistance or impedance at this point. I think it's a hospital oligopoly. I think they're the ones who benefit from people going to places. In fact, primary care doctors are owned in many cases by hospital systems. They feed in. UCLA here has a huge feeder network of primary care doctors 50 miles around UCLA that feed into that for anything beyond the most basic primary care, right? The second piece is integrated diagnostics, right? We're testing right now a service we don't make called Bina that allows you to take blood pressure by holding your camera up to your phone, your finger. And I think that that kind of stuff that gives the doctor more information in context of their conversation with you. And I think the third one is using the technology as an enabler to a doctor patient relationship. I sometimes use the analogy that telehealth has sometimes been like I can do Zoom, except I can only Zoom with the people that they choose on the other side of Zoom. I can't just use it as a technology to talk to anyone I want via video, right? It has to be more of an extension of my own doctor-patient relationship. And I think all three of those things are coming with, with ferocity and with velocity appropriate to the moment. Um, and the last thing I'll say is that it can't be five guys on this call, right? The people who create these solutions of tomorrow have to look like the users of tomorrow more than, five fairly privileged dudes as far as these things go.
Yeah, I think that's right. I think you're seeing very naturally a proliferation of specialized telehealth use cases, everything from the urgent care where the industry began to now pushing erectile dysfunction or birth control on an ongoing basis for a very specific use case. Um, Mental behavioral health being another very big one. Um, what you're going to start seeing is an importance placed on exactly what Nick just said, the longitudinal care from a consistent provider or team of providers that take care of you and orchestrate that care. And so that involves kind of an orchestration function, ideally led by a primary care doctor with whom you establish an ongoing long-term relationship, and then players within that ecosystem that help enable an omni-channel experience where it's not just about what can you do virtually, but it's about the harmony between what is being done virtually versus what will be done at home versus what will be done locally in brick and mortar walls, and then the beautiful bi-directional flow of information and patience across all of those channels. And so I think what needs to be done to move virtual care forward is for innovators such as ourselves and so many of the new entrepreneurs in the industry to think about how to enable this holistic, ongoing, longitudinal vision that goes well beyond if we just got a patient to call in to get an antibiotic for their UTI, which was a big win, right? As John and Mike already said, that's no longer enough. That's not what's going to get us the sustainable repeat engagement that consumers are ultimately going to need and what businesses are going to require for their economics to work.
Yeah, I agree. What got us here won't get us there. So well said, Sean.
Yeah, exactly.
And Sean, like starting with you, if we can kind of talk a little bit about part of it was mentioned within everyone's statement there, but I guess from a regulatory perspective, so I was talking with everyone a little bit about I'm from the credentialing and licensing space, and I know there's a lot that needs to change there to continue to move virtual care forward. But is there anything, Sean, that you would quickly add to your statement as far as what we need to do to move forward on the regulatory side of things? Now, this often is out of all of our hands, right? Obviously, there's lobbying and things that happen, but these are kind of, I guess you could say, almost like a wish list of things that need to happen from a regulatory side of things. So starting with you, Sean, is there anything you would add to that, or um,
I would say that on medical records privacy, we're pretty good where we are. It's the right practical balance with GDPR on one extreme and kind of no regulation on the other extreme. I think the United States, from a medical record privacy standpoint with HIPAA, is in a good spot. Where we're in a very bad spot still is, reimbursement and physician licensing and credentialing. There needs to be more standardized coverage for telehealth across all payers, public and commercial, in all states. And then we need to just tear down these stupid walls where a physician licensed in one state cannot see a patient in another. Otherwise, we should be sending doctors only to medical schools in the state where they're going to practice too, but we don't do that. So we're just internally inconsistent and the laws are grossly outdated.
Yeah, I would say that the most important thing, and just piggybacking off of what was just said, that the single most important thing is just to not treat it different. It's healthcare service delivery, and it should not matter whether it's virtual or physical. It should matter if it delivers the appropriate outcomes. And if we measure against quality and value as opposed to number of interactions, then a virtual visit can, more frequent virtual visits can deliver better quality than less frequent in person visits because you have an ongoing relationship rather than a transactional, I see my doctor once a year because it's such a pain to go thing, right? So I think just dropping that barrier or distinction entirely, people don't call it I'm dating by FaceTime or I'm dating but in person. They just say I have a date, right? I'm watching a movie. They don't say if it's streaming or DVD. They just say I'm watching a movie. In the same way, I think we have to drop the distinction. It's a distinction without a difference at this point.
I mean, parity laws, you're right. Parity laws have to be enforced now and in the future for both commercial and Medicare and Medicaid. And then also as cross-border practicing, as Sean said, has to be relaxed because I think I've got 30 state licenses still, and it is expensive, ridiculous, and incredibly time-consuming to try to do that. So those days have to end.
So to that point, we created a program at Teladoc that we called SuperDoc, and we took guys just like you, John, and said, "Hey, we're going to license you in multiple states." But Sean, I got a question for you. Are you saying that people in Oklahoma are the same as the rest of us?
Maybe
Not,
You've
not.
been to
I know
Oklahoma?
it's a
No, I'm
gross
just kidding.
assumption.
not
I'm
Oklahoma.
just kidding.
Nowadays, that's less true
No,
than ever.
Uh, no, I'm just kidding. So, but the problem is, I think it goes back to sort of a bureaucracy thing because those boards of medical examiners that control the doctors are like a fiefdom, and every state has one. And how do we get past that? The COVID helped relax it quite a bit, but I see it coming back pretty fast.
and I'd like to quickly shift focus, and we can start with you, Michael, as we get towards the end of this podcast. Without sharing each person's strategy here, right? The stuff that you don't want to share. Give us kind of paint us a picture, as a group. What could the next 5, 10 years look like? Let's say that some of the regulatory changes that you want happen, some of the items that you've identified to move virtual care forward post pandemic happen. What are we going to be looking at potentially in the next 5 to 10 years?
Yeah, I think my perspective is one of the senior executives at one of the big plans said to me, we can't really be preemptive. So I want to just step to the side for a second and say, what is it that I'm talking about? If I call United or Blue Cross or whoever and say, I want to do a high-end physical, they'll say out of pocket expense. If I want to do a genomics test, they'll say out-of-pocket expense. And those are the things that uh, they haven't paid for. When I get sick, if I get cancer or anything else, they'll cover my expenses and they'll be there for me. But if I want to be preemptive, if I want to catch things before they become dangerous and expensive, they call it a out-of-pocket expense. And that's the thing that those of us who are innovators, for John, Sean, Nick, we've all started these companies thinking we were going to change everything, and access to care and the cost of care, and why does my sister-in-law get diagnosed with cancer, stage 3 or stage 4? We can catch this. Um, but we're not. And so that's the thing that when we really fix our healthcare system, it is because we're teaching people how to be preemptive. We're showing them how to make their immune system strong. We're showing uh, the individuals ways that they can catch things before they become dangerous and expensive.
Yeah, I would just tag on that. I mean, it's got to go towards personalized medicine. And, Michael aptly describes that as preemptive. And, I've done all sorts of pharmacogenetics testing and genetics testing to see what I'm at risk for. I'm adopted, so I don't really have any family history that I know of. But now I know all the medications I can take, all the medications I should stay away from, things I should be concerned about. And yeah, I paid for it out of pocket because it was worth it to me to have some sort of, as opposed to my telephone poll family history, it was worth it for me to have a little background. But I think using personalized medicine to ultimately lower the cost of care and improve health outcomes it has to be where we end up, and hopefully it'll be within 5 years.
Yeah, and I think, and I want to echo what Michael said because I think it's so important, right? I've made this joke before that when you start a health tech company, you start out thinking you're going to change everything, and then you're lucky if you change anything, right? Um, because it is so hard. But I think we have a unique sort of generational opportunity because of confluence of factors that we've talked about to really move towards a preventive and predictive healthcare system that uses digital technologies to substantially lower the cost. I often use this analogy. It's like instead of my kids being in school learning what they will need to know, it's like they face a problem as adults and they, oh, math. Oh, okay, let me go figure out how to add two and two. That's how insurance thinks about it. Health insurance operates in the same way car insurance does, but car insurance is built on the notion that the person driving the car doesn't want an accident, the insurance company doesn't want you to have an accident, right? Except healthcare works the opposite. It's like education. The more preventive and early it is, the better the overall costs are and the overall outcomes are better. And I think that the advent of digital diagnostics, personalized medicine, and a universal access point, which is the mobile device and connectivity, really have a chance to bring that to life. And I sincerely hope to be part of that. But even if I'm not, I hope it happens for the better of all Americans and all humans.
Yeah, I'll try to answer this maybe from a market's perspective. I think the next 5 years, you're going to see a further proliferation of point solution devices, apps, algorithms that do a specific job. But then simultaneously, you're going to see through M&A a lot of consolidation and platformization of a lot of those point solutions, either through like third-party marketplace models where one platform enables access to a bunch of different verticals of use cases, or through actual consolidation and acquisition and roll up of many of these companies that have innovated in their own way but now being bundled together under single contracts with respective enterprise customers. I think the other thing you'll see is graduating the conversation from contracted eligible lives to actual usage and outcomes. The market, the public markets and industry analysts in general have been pretty forgiving in saying, okay, you have a lot of contracted revenue because you're covering a large population with your telehealth solution, but that is quickly becoming insufficient. Now they're going to the question, well, how many people are actually using your service out of that eligible population? So companies are going to have to get a lot more savvy about engagement, adoption, and the marketing programs and how effective they are at actually driving usage. And as you do that, you're going to find companies that get better at consumer engagement marketing, realizing that we don't have to be beholden to B2B models, that they are direct to consumer models, which might be just as big, if not bigger, than where the industry started in B2B, because that was the easy access to distribution. You work with an employer, a plan, a health system, you get access to a lot of patients in one go. But there is a growing segment of the American consumer market that is uh, the rise of the 1099 gig economy worker, the rise of the high deductible plan, right? There's just growing portions of the American population that do not get good coverage with their insurance plan. And they're not waiting for an email from their employer to learn about a telehealth solution. They're going on Google, they're going on Facebook, and which brands are raising their hand saying, I can serve you in answer to your health question. I think a lot of the vision that I'm sure Cheryl at Walmart saw in John, the asset you built, is bringing some of that vision together, right? Is meeting consumers where they are and integrating a whole bunch of services for them.
As we wrap up basically in the next 3 to 5 minutes, this is the part of this episode where everyone gets to kind of give their plug. So basically, starting with you, Sean, we'll just kind of go back down the lineup here. Tell us a little bit about how HealthTap is playing its role in the future of virtual care, and then we'll go Nick, John, Michael as we wrap up.
I'll keep it relatively short. HealthTap is really focused on reaching American consumers directly at a price point they can afford, regardless of their deductible or insurance coverage or employment situation, with a membership-based primary care model that they can buy with a credit card and not worry about the cost. And like I said, with the more than half this country that is underinsured, with the billion health searches happening every day on Google to health questions, we're trying to get in front of those consumers where they are and offer them a long-term relationship with a primary care doctor through our app.
Yeah, I will say that before I even say what we're doing, I wish I got to be John in this, and because he's like, look, I'm trying to decide between the Lamborghini and the Bugatti. I've sold my company to Walmart now, and my next steps are uh, jet or yacht. Okay, so congrats to you, John. It's a long road you hoed. I remember meeting you 7 years ago. Um, and wonderful to be on this panel with everyone. I think what we do at HeyRenee is whole person horizontal digital care coordination. That a person isn't a diabetic, separate from a hypertensive, separate from obesity, separate from mental health, separate from. They're all those things. They're a human being named Juanita Gomez or Jane Smith, and only if you coordinate all aspects of their care using various digital tools to work together, you can't coordinate any aspect of their care. Um, that's what we do at HeyRenee. And again, it's been a real pleasure to talk to John and Michael and Sean and Jared. Thanks for putting these wonderful things together.
So my little small piece of this is I'm working with Walmart as a consultant, just to help them deliver their omni-channel care. And there's a Walmart within 10 minutes of 95% of the U.S. population with their 5,000 stores, so they can make a big impact in healthcare. And the leadership there is absolutely committed to doing that. And so, that's my small slice of the modern healthcare today. And thanks, Jared, for putting this on. Jen, so it was great hanging out with you.
So I'm just glad I didn't say Arkansas. I said
Oklahoma.
Oklahoma. Yeah. So, the one thing that I can say, sort of as the old historian in this um, podcast, is that the industry has finally reached the stage where we can say we are no longer an emergent industry. We are now a growth industry, and the fact that John's company was bought by Walmart, I guarantee you CVS is going to make an acquisition this year. And so, our my company, Recuro, I said is all about being preemptive. But if you think about what all of us did, people can call it telemedicine or digital, whatever. But what we really did was we brought efficiency to healthcare. And so, what I'm trying to do at Recuro right now is I'm trying to find all those assets out there, the technology, the great ideas that will be crushed in this consolidation phase. and I'm trying to bring them into a company that gives them the resources they need to become what they should become. And we call it a digital medical home, but ultimately, I've seen a company that I started with John Halsey a couple years ago, and we're going to pass the $200 million valuation point based on a reasonable multiple this year. And so, it's fun being on this rocket ship, and I look forward to catching up to you, John, and having the yacht or the. I'd rather have the rocket ship decision, but whatever.
Well,
You and Elon.
I'm a landlubber. I'm going with Lamborghini. I don't want to be in the sky.
There you
I don't want to be in the water. I like land. Okay.
Well, gentlemen, it's been an absolute pleasure. I'm glad we were able to get this group together and so quickly to come on this first episode of Titans of Healthcare. The goal will be to have you all on again at some point, whether it's this same group or it's one-offs, and we kind of mix and match with some other areas of virtual care and beyond. But really appreciate everyone joining us here today.
Yeah, guys, I'm humbled. Thank you for letting me speak alongside you.
Same.
Thank you.
Yeah.
Yes, indeed.
Yep.